Good morning, ladies and gentlemen. Thank you for being here so early. It's a pleasure to open this session of Aficardio this morning in the presence of the President of the French Society of Cardiology, Professor Hagage, Professor Lotan, the President of the Israel Heart Society. And I would like to ask Professor Hagage, our first speaker, to deliver the lecture on echocardiographic assessment in hypertrophic cardiomyopathy.
Hello, good morning. It's a pleasure to be there. Thanks to the Israeli Heart Society for their kind invitation. Thanks to Haim Lotan. Thanks also to Dr. Ben Soussan from Aficardio for his kind support. So, echo in hypertrophic cardiomyopathy, four main roles: diagnosis, first, prognosis, therapeutics, and screening. Well, diagnosis, you know all that. Unexplained hypertrophy, more than 15 in sporadic cases, more than 13 millimeters in familial cases, a small left ventricle, usually an asymmetric hypertrophy. However, we know since a few years that some people with morbid mutation do not have any hypertrophy. It's very frequent in the child and adolescent, obviously, but also in adult patients with morbid mutation, particularly protein C mutations, which are quite frequent in France. About 30% of all cases have no hypertrophy at all and will develop hypertrophy with age between 30 and 50 years at the adult age. Well, we know that the usual cause of HCM is sarcomeric gene defect with an autosomal dominant transmission, but there is a lot of causes, many causes of hypertrophic cardiomyopathy. If sarcomeric is the more frequent, there is syndromic hypertrophic cardiomyopathy, which is quite rare. There is lysosomal enzymopathies, like Fabry or Danon disease. There is mitochondrial diseases, which often happen in adults. And there is amyloidosis. And all those causes need to be excluded before having a diagnosis of sarcomeric hypertrophic cardiomyopathy. So the first diagnosis is differential diagnosis. Well, obviously, when there is that sort of patient with obviously a malformation, you have to think about other diseases like Noonan disease. When there is cutaneous signs like those angiokeratoma, you have to think about other diseases like Fabry disease. And when there is that sort of pedigree, which is compatible with an X-linked transmission, you have to think about Fabry disease also. So you have to look outside the echo. And the main problem is the sporadic patients with only echo abnormality, only left ventricular hypertrophy. Is it truly a sarcomeric hypertrophic cardiomyopathy or not? That's the main question. Well, you can do genetics, but the genetic profile is not systematic and always patient-orientated. And two, when you search for a sarcomeric mutation, a negative test is frequent, 40% of all cases, and it doesn't mean that there is no sarcomeric gene defect, because we do not know all the gene involved in sarcomeric HCM. So genetics is not always the solution. So you have to have red flags to think about other diseases that can cause hypertrophy. Well, first red flag by echo is concentric left ventricular hypertrophy, which is more frequent in amyloidosis, mitochondrial diseases, Fabry diseases, for example. When you have global left ventricular hypokinesia, with or without left ventricular dilatation, you have to think about other diseases like Fabry, mitochondrial diseases, amyloidosis, etc. When you have pericardial effusion, it's not so frequent when you have a sarcomeric hypertrophic cardiomyopathy, and you have to think about other diseases like amyloidosis. And finally, when you have right ventricular hypertrophy of increased thickness of the atrioventricular valves, you have to think about other diseases like amyloidosis or Fabry. So you have a lot of diseases that can mimic, in fact, the sarcomeric hypertrophic cardiomyopathy. So here are some examples of amyloidosis with a concentric left ventricular hypertrophy and pericardial effusion and pleural effusion. And here you have a mitochondrial disease in an adult patient with right and okay, with right and left ventricular hypertrophy and hypokinesia of the left ventricle. So this is a Fabry disease with massive hypertrophy and hypokinesia, but you see that the hypertrophy is either concentric or not predominant on the septum. So this is quite non-typical for a sarcomeric hypertrophic cardiomyopathy. And finally, in Fabry disease, there is sometimes that binary appearance of the myocardium. You see that it's more dense here at the intern part of the myocardium, and it has been described in Fabry disease. So you have to think about other diseases than sarcomeric HCM. The problem is the true cardiac variant, meaning that some people with Fabry disease will express only left ventricular hypertrophy or cardiac abnormality. We did the focus study with the help of the French Society of Cardiology in France, including about 400 patients with hypertrophic cardiomyopathy, which were followed, in fact, in cardiology practice in town or in current clinical practice. So all of them were supposed of sarcomeric origin. We did a systematic dosage of alpha-galactosidase A, which is decreased in Fabry disease. And if decreased, we search for the morbid gene. And we confirm Fabry disease in 4 male patients, meaning that about 2% of all male that you follow for a sarcomeric hypertrophic cardiomyopathy, in fact, has Fabry disease. And it's important because they might have some specific treatment to improve their condition. Well, in those patients, 3 had a pacemaker for an AAV block. All were asymmetric, have asymmetric left ventricular hypertrophy. 2 were obstructive. 1 had alcoholization. So you see, it's really typical sarcomeric HCM, but it was not sarcomeric HCM. And more than that, we identify 8 patients with Fabry in the families of those 4 male patients. So in some instances, in your cohort of hypertrophic cardiomyopathy patients, you have Fabry disease. It's the same with what we call transthyretin amyloidosis, TTR amyloidosis. Well, it's a genetic disease, autosomal dominant, like a sarcomeric hypertrophic cardiomyopathy. And if you look at that Italian registry, which compare amyloidosis TTR with senile amyloidosis and hypertrophic cardiomyopathy, about 20% of all those patients with amyloidosis TTR had in fact only left ventricular hypertrophy. But all were male, more than 65 years, had heart failure signs and severe heart failure, symmetric hypertrophy, and moderately depressed ejection fraction, 35 to 55%. So when you have a male patient, more than 65, with heart failure, with concentric and symmetric hypertrophy, with low ejection fraction, you have to think about TTR amyloidosis. And the diagnosis is genetic. And it's about probably 1 to 2% of all patients with hypertrophic cardiomyopathy. So echo is not the only picture of HCM. You have to look at biology, and you have to make some systematic biology exams, like searching for leukocytopenia, which is frequent in mitochondrial diseases, searching for increased CK, muscular CK, or liver dysfunction, searching for abnormality of the protein electrophoresis, searching for kidney dysfunction with proteinuria or creatine level, which might orient towards a non-sarcomeric hypertrophic cardiomyopathy. The other biology tests are not systematic, only clinically orientated. But you have to perform some systematic biology exam. So you have some other red flags, either clinical. If you have any clinical abnormal signs, you have to think about non-sarcomeric disease. But also the ECG, just do the ECG systematically when you do the echo. Just look at it. A short peer interval, it might be a Fabry, mitochondrial, or Danon disease. An AV block with or without pacemaker, think about Fabry disease. A low QRS voltage despite hypertrophy, think about amyloidosis. So there is a confrontation between ECG and echo. Finally, the athlete. The athlete is a problem, as you know. In the athlete, you have an increased thickness, usually concentric, usually moderate, 13 millimeters here, and an increased volume of the left and right ventricle. This is a cycling male doing competition. So what are the thresholds which will bring you to the diagnosis of a disease, well, the thresholds are there. In the adolescent, in fact, before 18 years, hypertrophy doesn't increase above 12 millimeters in male and 11 millimeters in female. And in male, when it's 13 or 14, which is quite not frequent, the ventricle is dilated and the H-on-A ratio is above 1. In adults, all female have less than 11 millimeters. And a few male have more than 13, but all with a dilated left ventricle. So the alert is 12 millimeters in female, whatever the age, and 13 millimeters in male. When you have that, it's perhaps an hypertrophic cardiomyopathy, particularly when the left ventricle is not enlarged. So deconditioning, just ask them to stop 8 weeks if they can, if they want. And in all cases, hypertrophy decrease below 13 millimeters after 8 weeks of detraining, all cases. You can also do a strain. Strain is normal in athlete, and it's abnormal in HCM. So even here, if you look at the athlete of the Tour de France, you see that less than 1% of all the athletes have more than 13 millimeters of thickness and less than 55 millimeters of diameter. So the enlargement of the left ventricle is important to take into account. Well, what about prognosis? First of all, malignant hypertrophy, which is hypertrophy more than 30 millimeters, it's 1 out of 10 patients, but it's 1 out of 4 patients which will die suddenly. So it's a major risk factor for sudden cardiac death, and you have it by echo, only by doing an echo. 2, the restrictive pattern or end-stage pattern. Usually, the thickness is decreased, the ejection fraction is below 50%, there is a dilatation of the both atria, usually with AF or not, and this is very bad, and you see that at long term, the survival is really decreased as compared to patients with normal ejection fraction. So it's really a bad prognosis. Mid-left ventricular obstruction. Mid-left ventricular obstruction occurs at the level of the papillary muscles. You can have that by Doppler. And when you have obstruction, the survival is really low as compared to patients without mid-ventricular obstruction. And some of those patients might develop with time, you can see here from T0 to 4 years, that dilatation of the apex, which is an apical aneurysm, non-contractile apical aneurysm. And what happens when you have that? You can see that by echo here. You have that dilatation, akinetic apex. You see it here? It's 2% of all patients. But when you have that, each year you have 10% of patients which will experience sudden cardiac death, heart failure, or stroke, meaning that those patients need anticoagulation and they need to discuss a ICD implantation. What about resting gradient? Resting gradient more than 30 millimeters of mercury. This is the study from Maron. About 1,000 patients at baseline, you just measure resting gradient. And if you have more than 30 millimeters of mercury at 10 years, you are more heart failure and death from heart failure or stroke. It's essentially an increase in heart failure. There is also an increase in sudden death, which is, as you see here, not very impressive. Finally, left atrial dilatation. Well, above 45 millimeters, the risk of atrial fibrillation occurrence is very high. It increases. So the more the atrium is enlarged, the more the risk of atrial fibrillation. And you know that, at least in young age, atrial fibrillation is at risk, you say at young age, at risk of death, particularly of death by heart failure, but also by sudden death. So it's another prognosis indicator. Let's go through that. And also you have some benign HCM, like apical HCM, Yamaguchi disease. You see it here, and you see it also here. There's a very concentric apical hypertrophy. which is usually of benign course. What about therapeutics? Well, therapeutics, you have to search for search and quantify obstruction. And for that, you use either a Valsalva maneuver during the echo or an upright exercise. And you locate the obstruction. Is it in the outflow tract? Is it at the mid-ventricle? Is it significant, more than 30 millimeters of mercury? Is it more than 50, which will make you to discuss invasive therapy? So 2, you have to describe SAM. Is it only the anterior leaflet or both leaflets causing SAM? 3, you have to search for papillary muscle insertion abnormality. It's up to 10% of all patients with obstructive hypertrophic cardiomyopathy. Usually it's a direct insertion of a sheath of the posterior medial papillary muscle inserting directly on the anterior leaflet. It's quite bad, usually causing severe obstruction and leading to surgery. Okay. And 4, you have to quantify leaflet elongation. In more than 50% of all patients, leaflets are elongated. You see here the very, very long posterior leaflet causing SAM and also causing obstruction. And also causing obstruction, as you can see here. No, you will not see here. Okay, doesn't matter. So you can appreciate leaflet length. You can measure anterior and posterior leaflets. You see here that the anterior is 28 millimeters, which is quite long, and 18, which is moderately elongated. And we know that from Levine work that the longer the leaflet, the larger the mitral valve area by 3D echo, the more severe is the outflow tract gradient. So there is a clear relationship between mitral leaflet elongation and obstruction. Finally, by echo, you just search for any indication for alcoholization. I will not go through that, but the ideal indication, upper septal hypertrophy, more than 18, leaflet SAM, and no mitral valve abnormality, no structural mitral valve abnormality, no direct papillary muscle insertion. And if the patient is very severe, well, you can discuss alcoholization. And sometimes you have that sort of thing after alcoholization, like a myectomy. So you see this is a patient post-TASH with a very good result, in fact. Finally, you can also appreciate end-diastolic pressure to discuss, in fact, the interest of a diuretic. So there was a study a long time ago by Nagé telling that the simple ratio of E at the mitral annulus, at the mitral inflow, to the E at the mitral annulus, E on EA ratio, can indicate an end-diastolic pressure above 15. Well, a more recent study told us that it's not so clear. In fact, if you see patients with a E to EA ratio more than 15, the vast majority have, in fact, high filling pressure, but some of them have also low filling pressure. So it's an indicator. It's not 100% sensitive or specific. And finally, familial screening. Familial screening, it's for first-degree relatives. And you remember that study from McKenna in heart, 1997. It's always valid. Major criteria, if you have wall thickness more than 13, it's the diagnosis. If you have severe SAM, you can do the diagnosis. And you have minor criteria, and you need 2 minor echo criteria to make the diagnosis. Either wall thickness equal 12 and long mitral leaflets, you can do the diagnosis. And if you don't have that, you can combine ECG abnormalities. So it's not easy, but you have rules here. And you know that appreciating by DTI the velocities at the mitral annulus can indicate the presence of a morbid gene, at least in the young people, the young being less than 30 or 40 years. And you see that 12 centimeters per second is a ratio and is a threshold, and whatever the septal systolic velocities or septal E velocities, less than 12, may indicate, in fact, that the patients carry a morbid gene. When do you have to do a family screening? Before 12 years, it's optional. Between 12 and 18 each year. After 21, each 3 to 5 years. But you have to start before, probably at 5 years of age, if there is a family history of sudden cardiac death, and to be more systematic if the children, for example, is doing competitive sports. So I hope I have convinced you that echo remains a major tool in hypertrophic cardiomyopathy. Thank you.
Thank you, Professor Hagage, and also for being in time for one or two short questions, please. Would you agree, I would like to ask you, would you agree with what in the paper actually you showed us more than once, Felicia and Maron, published for distinguishing athlete's heart from hypertrophic cardiomyopathy, that you said it should be more than 1.3. They also said another thing, it should be less than 1.6, maximum 1.7, that they never saw a sickness, wall thickness in this paper, which was in elite athletes more than 1.6, 6, 7, or in dilated hearts, they didn't see a ventricle which was more than 6. It was more than 55, but it was never more than 6 in athletes.
Yeah. Well, for the 15 millimeters threshold, I agree. It's exceptional that you have more than 15 in an athlete. For the 60, I'm not sure. Well, in the Tour de France, for example, we did a systematic screening of all athletes. A lot of them have more than 60 millimeters.
Really?
I know that in the Tour de France, you know, they are doing a lot of things. Yeah. Not only sickles, but corticosteroids, etc.
The second point I would like to make, if there is no question, is that I just want very much to strengthen what you said about the paramount importance of echo in amyloid, including senile amyloid, which is a quite frequent disease of the TTR amyloid. And the point is also, Rapezzi showed that, but it had been shown in many previous papers also by others, that only 2/3 of the patients have low voltage by electrocardiogram. You said that, but I want only to strengthen that. And actually, it's not so important the low voltage to make the diagnosis of amyloid as to combine it with the echo and to see the discrepancy between the voltage on the electrocardiogram and the left ventricular hypertrophy we see on the echo. And this ratio of discrepancy between the echo and the echocardiogram is more important than the real presence or absence of low voltage, if you agree.
Yeah.